We spend more than $60 billion a year on healthcare in Ontario. Yet many experts agree that we could spend twice that amount and not necessarily have a healthier population or a system that's twice as good. A different option may be, can we innovate our way to a better system and better outcomes for patients? To that end, we've assembled 4 healthcare experts, all of whom have some ideas which, in their view, would make things better. And so we welcome Dr. Dave Webster. He's adjunct professor in physics and neurosciences at Laurentian University in Sudbury. Kate Mulligan, Director of Policy and Communications at the Alliance for Healthier Communities. She's also Professor of Social and Behavioral Health Sciences at the Dalla Lana School of Public Health at the University of Toronto. Natalie Mehra is here. She's Executive Director of the Ontario Health Coalition. And Stephen Skivington is the President of Polytrain Inc. That's a public relations consultancy. He's also the author of the just-released book, This May Hurt a Bit, Reinventing Canada's Healthcare System. That's a great title. Thank you, first of all, for coming all the way down from Sudbury to you, and thank you for driving in from Cobourg today. You drove or took the train?
I drove.
You drove in. Thank you for doing that. Kate and Natalie, great to have you here as well. Let's start. Kate, I want to start with you, and I'm going to read something off your website, okay? Yeah. Sheldon, let's bring this up and everybody can read along. What if, along with medication, doctors and nurse practitioners were enabled to prescribe dance lessons, cooking classes, volunteer roles, caregiver supports, single-parent groups, and connections to bereavement networks? Every point of contact you have with the health system should be a gateway to better overall well-being, particularly in primary care, which is most people's main point of contact with Ontario's healthcare system. Kate, you are describing something called social prescribing.
That's it.
What does that look like?
Well, social prescribing is really, rooted in an old idea that we are healthier when we're in community, and that what we're finding is that there can be a role for the mainstream health system in helping address the growing body of evidence that people's, social and environmental determinants of health are really key drivers of their overall well-being.
So you are now prescribing. You are social prescribing at, is it 11 community health centers around the province?
Yeah.
How's that going?
So we have 11 different centers, and they're in really different kinds of contexts. So in Thunder Bay, for example, a rural francophone center in Timiskaming, some downtown centers here in Toronto. And they're all trying in their own ways to help better connect people with social supports for their health needs.
Can you tell whether people are actually healthier because of this different approach?
That's our goal. So we're early on in the evaluation process right now. We're learning and working with people from the United Kingdom who have been doing this for a little while. And so we are implementing a very robust evaluation using our shared electronic medical records and lots of research to see whether that's true. But early indications are that, yes, people's health, their self-reported health and well-being, their self-reported sense of social inclusion and drop in loneliness, we're already starting to see anecdotally that, yeah, people are feeling healthier.
Is there an acceptance in the broader healthcare system that this is the way to go?
I think we do have a ways to go before that's the case. And that's partly why we're working so hard to build the evidence base. We need to help work and convince other people. But, we've been approached by a number of people within healthcare organizations, as well as arts organizations, ecological organizations and parks to come and partner on with this, including some major hospitals. So I think that there's a really, really strong interest and that there will be acceptance if we can help speak to the evidence that they think is important in determining people's health, as well as the evidence that we also know is important with respect to how people view their own health.
Okay, if this is really bare bones, basic, on the ground, community engagement, I want to go to the exact opposite end of that spectrum. And Dr. Dave, that's where I get you in, because you're a neuromedicine guy.
Yeah.
You are a guy who's in love with PET scanners.
You got it.
What's a PET scanner?
Well, a PET scanner is an instrument. We image, in my specialty, metabolism or physiology directly at the cellular level. So we inject literally less than a billionth of a gram of a radioactive substance which traces metabolism. The most common one we use would be glucose, or simple sugar in a modified form. And why that is so helpful is because every cell in the body can use sugar to metabolize, but particularly its major use in cancer is cancer cells can only use cancer, and they do so extraordinarily inefficiently.
What does PET stand for?
Positron emission tomography.
Positron?
A positron is a type of a radioactive decay.
Okay, and you use PET scanners because they're better than other kinds of scanning. How?
Well, the problem is people are familiar with things like CT and MR. They have an exquisite ability to look at anatomy at the 1 millimeter resolution. The problem is they have virtually zero ability to determine whether a mass they see is a cancer, scar tissue, or, say, an infection.
That's for a CT scan
For a
or an
CT scan
MRI.
or an MR. In other words, they image what we call anatomy or structure, and we image function. A good example would be when a patient has had a cancer treatment, they're often left with a mass that's left. And in Ontario, uniquely in the world, we simply follow them with CT scanners. The problem is the CT scanner has zero ability to determine whether it's scar tissue or...
But a PET scanner can.
It can, because you see, if it's scar tissue, it takes up almost no, none of the sugar, but if it's a cancer persisting, it will. And I've seen patients, as a simple example, treated for lymphoma, multiple CTs, said, look, everything seems fine, go home, have a nice time with the wife and kids. He heard about a PET scan, I read it, and we found not only was those masses still active cancer, he had 4 new sites they didn't even know about. So the next day he was on the most aggressive treatment we have.
So in your view, if we were going to have much better health care in the province of Ontario, we'd have more PET scanners available to more people?
Well, absolutely. And I think an indication of that is back in 2004, one of the most prominent people, and I trained under him, Dr. Al Dreger, wrote Mr. Smitherman, and at that time said...
The then health minister, George Smitherman.
Yes, sorry, the health minister, and said, we are a decade behind the world in 2004. Right now, we are not even on the same planet.
How many do we have in Ontario?
We have about 12 or 14, but it isn't how many we have, it's how we get to use them. If we look next door in Quebec, they have the same number of scanners. They have the same... they have half the population of Ontario. They scan on average 3,000 patients per camera per year. In Ontario, we'll only be allowed to scan 800 patients, but that's not the bad news. The bad news is that the indications that as a physician I am allowed to use to do those PET scans is the exact opposite of the entire world expert body of opinion. And if I were to use those indications in Quebec, or for that matter Paraguay, that I could and should be charged with incompetence. And I see the impact on patients on a daily basis.
How much do they cost?
The PET scanner itself is probably around 3.3 million.
So is that one of the reasons why we don't have more of them?
Well, I don't think that's quite, well, it initially was. It's not now, I would argue. But the point is that because PET is able to do that, I can give you an example of a patient. And if you have a teenager with lymphoma, my advice would be leave Ontario. Why? Because I have a patient who's been followed for the lymphoma. They've had more than 30 PET or CT scans and counting. That's more than 300 years of background radiation exposure. The only time they were ever a treatment change was made was when they had 3 PET scanners, 3 PET scans, you see, because we can image the metabolism. If you have a teenage daughter with lymphoma, within 5 years, they already have to start screening her for developing cancers in her thyroid and breast, not because of the cancer of the treatments, because of the excessive, almost useless CT radiation she will be exposed to.
Okay. Thank you for that. Hold the fort. Stephen, you're up next. Ready to go?
Absolutely.
You have written a book that is going to be controversial as hell. Yes. And I can't wait till Natalie has a chance to have a debate with you about this. Here we go. You actually start by quoting, I read the book, you've got a quote in there from the legendary CBS News anchorman Walter Cronkite, who talked about America's healthcare system as neither healthy, nor caring, nor a system. Would you say the same thing about the province of Ontario?
Oh, absolutely. Our problem is that we don't have a healthcare system. First of all, it's a sickness system. It's treating sickness and not really about healthcare or keeping us healthy or nutrition or wellness. That's a big problem. But the bigger problem is that it's really just an insurance scheme. It's an insurance scheme. I say it's a badly run insurance scheme. And for example, people keep asking me, when you wrote this book, did you find anything that surprised you? I was surprised to discover the Canada Health Act, that everyone's waving around like some great flag of patriotism, is actually a finance bill. It has virtually nothing to do with healthcare. The 5 principles are there.
Well,
Tommy Douglas had 8. We only took 5, but it was actually about ending extra billing and co-payments and all that stuff. It's a finance bill that we're getting bent out of shape over, and trying to suggest that defines us as Canadians. It's ludicrous.
Well, let's just go through this, because not everybody knows about this. It's been around for 35 years after all. But essentially, the Canada Health Act has suggests 5 things that our system ought to have. It ought to be public, it ought to be comprehensive, it ought to be universal, it ought to be portable and accessible. What's missing on that list?
Oh, quality. And for example, when what led to my writing this book is, as I was in the back of the ambulance having dropped dead with my heart trouble, I said, if I actually make it to the hospital and live through this, I'm going to write this damn book finally. But if I had died, it would have been the exact same as if I'd been successfully treated, because the list would have gotten one body shorter in our system of bean counting. And again, because it's an insurance scheme. Quality, I say, at Ford, quality is job one. When it comes to Medicare, quality is job none. And that's, I think, a big part of the problem. I would want quality to be a sixth principle of the Canada Health Act, but I'd actually make it the first principle.
Does it not go without saying that the people who are involved in our healthcare system want it to be a quality system?
Oh, absolutely. But again, leaning back to Ford, before Ford decided that quality was job one, it was let's get the product out the door as fast as possible. And that's what happens. People who've never used our healthcare system say we have the best in the world. People who've had a problem, a serious life-threatening, like a heart attack or a car accident, say it's the greatest system ever, because it's like pulling into the pits at the Indy 500 when you've had a heart attack or you've been in a car crash. The whole pit crew jumps in there and they do a fabulous job. They work as a team, they get you back, save your life. But if your problem is not life-threatening, then it's like when we have a big snowstorm in a city like Toronto and they plow the main roads, and if you happen to live on a side street, maybe you'll see a plow 3 days later. That's the problem. And so we have these ludicrous wait lists, which are totally unnecessary. We are rationing healthcare. In the States, they ration it by the size of your wallet. Here, they ration it by wait lists.
Your solution in the book, you've got a top 10 list in the back of the book. I guess the most controversial recommendation you make is that you think we should allow the creation of a parallel private healthcare system.
Yeah.
If we did that, what would happen?
Well, first of all, people will always say, well, why should we give a second tier to the rich? Well, the rich already have a second tier. It's called America. They just get on a plane and go to America. The rich don't need this. The boomers, the zoomers, the middle class, we're the ones who need this. And there are polls out there that show 75% of Canadians are on side with this. I laugh about all of the political parties not wanting to touch the so-called third rail, because frankly, if you did touch the third rail and embrace this, you'd win a landslide in the next election. But the reason that we should do this is that it would open up so many things. It would open up money, it would open up time. One of the things people don't realize is the reason we have wait lists is because surgeons are only allowed to operate 1 day a week. And so the operating room is empty for the other 4 days. Now, that's not because we don't have enough surgeons. That's because we don't have the money to actually run the system. To pay for the hydro, pay for the nurses, pay for the whatever it is, they would keep it open 5 days a week.
So if you allowed those with means to purchase extra care, if you like, or however you want to describe it, you think that would reduce the wait list?
Oh, absolutely. And also, I'd allow for medical tourism, for people to come from other countries to buy services, for that money to go back into our public system. One of the great canards is that myself and Dr. Day are pushing for a private system. Get rid of the public system.
Brian Day from BC.
Yeah, right. Get rid of the public system and have a private system. We're saying no, both together. That's the way to work. Because really, when you think of it, touching the third rail is how the train operates at its maximum efficiency. We need to touch the third rail for our healthcare to operate at maximum efficiency.
Here's where we go to the Ontario Health Coalition and we say, Natalie, what do you think?
Oh, I wish I had a chance to talk about innovation, but I will respond to that.
Well,
I think I have to.
Let you respond to that, and then we'll touch on the innovation piece.
Yeah. So unfortunately, what we're talking about here is not really innovation to improve the public system, but actually to dismantle the public system and to create a private insurance system as well. I take issue with a few things. One premise that we spend $60 billion on healthcare in Ontario, and nobody really knows what that number means without context. And the truth is, in Ontario, we actually spend among the least of all the provinces. There are several different ways to measure it, but we're
per capita, you mean?
Per capita on our hospitals, we're third from the bottom, in terms of GDP. By every measurement, we're right down near the bottom of the country. So one, is there evidence that we're spending too much? No. Could we spend that money better? Of course. Two, I think our starting point should be that we have a stellar healthcare system, highest educated health professionals, doctors, nurses in the world, according to international studies, amazing care, and I can attest to also having had heart problems, really stellar healthcare, and that matters. So a sickness system that provides for people when they're sick is important and ought not to be tossed out in the name of expanding care in order to provide more comprehensive preventive care. And it's also a misnomer to say that the health system does not provide preventive and health-enhancing care. A whole lot of home care is preventive. All of long-term care virtually is preventive care. The community health centers are an innovation model, team-based approach within the public health care system that provides all kinds of preventive care and health supporting care. There's all kinds of that activity happening within the healthcare system already. So when we have these innovators that move in and they want to take over parts of the market share in healthcare and they see it as a market to break into, often for profit, they often try to create a crisis out of the system, talk it down in order to ratchet open the ability for them to move in and take over.
Let's take one thing out of what Stephen said there. He talked about empty operating rooms because the system is mismanaged or whatever. Is that a fact? Do we have empty operating rooms here?
We have closed down operating rooms in all of the large hospitals in Ontario. And what we would say is we have the lowest hospital funding in the country. Improve the funding, open up the operating rooms, and deal with the wait lists in the public system with the principle that access to care ought to be based on your medical need and not how much money you have. The truth is, in BC, where Dr. Day is operating his private hospital, patients are charged, they bill not only the public system, but they bill patients on top thousands of dollars per surgery for their medical care. That's only available to those people who can pay thousands of dollars per surgery. That's not out of altruism to improve healthcare for everyone.
Does that open up the backlog, though?
It makes, well, no, I mean, they don't, they're agnostic as to what the level of need are for their patients. The private clinics don't, for example, the private hospitals in Ontario, they don't have ICUs, so if you code, they can't deal with you. They don't deal with the people with diabetes and the heaviest care needs. They leave those for the public system. They take the easy, profitable, fast patients, they do those, and they leave the heavier care for the public health care system.
Okay, let's get into one idea you would bring forward in terms of innovation that you think would improve the healthcare system in Ontario.
I think we need to look at improving access to care fundamentally and innovations around improving access to care.
What does that mean?
Well, we have long wait lists. We have a long wait list, and so we should be looking at ways in which you get the surgical wait lists out of your one surgeon's drawer, and patients actually have the ability to know openly, not on a website that no one knows about, but openly, where they can actually get care quicker and have some of those choices given to them openly by their family doctors or by their referring whoever that is.
So a bit of a registry then.
A registry of some sort that would actually be much more available to patients with much more upfront information. But also, let's look at the huge need for seniors' care, like where social services meet healthcare. Could we not create a model like the CLSCs are in Quebec, where we have a meeting of the social service needs of seniors and the home care and the long-term healthcare need of seniors within the public system on an equitable basis to really keep people as healthy and as independent as possible for as long as possible. Those things would make a tremendous difference for millions of people.
Okay, let's get into some discussion here. Let's start. You two ironically see the same problem.
Yeah.
You actually see the same solution. You just disagree, if I understand it, on what pocket the money ought to come from. You want a parallel private system with private people paying into it in order to help.
Who owns it and
you want the
whose
taxpayer
interest?
too.
Well, who owns it and in
Okay,
whose
but hang
interest?
on. Let me go back to him then. What's objectionable about what you just said?
Well, a couple of things. Let me just talk about the BC situation, for example. So the NDP government in BC spent $20 million on 20 lawyers in the first 6 months of the Dr. Day's Charter Challenge. That's taxpayer dollars to keep sick people on the wait list who also end up dying on the wait list. I think that's disgraceful. This is what our government does. As far as solutions go, innovative solutions, like I'm all for innovation, I'm all about innovation, but here's the problem. Governments always try to solve the political problem. And let me use the current, I'm going to take a shot at Doug Ford, despite being a conservative. They are trying to end hallway medicine. So we're going to throw money at the hospitals to open more beds, okay? That's not what the problem is. The political problem is that, and they can cool things down in question period if they do that, but the problem is the so-called bed blockers, which I like to refer to as human beings. They did a study in Hamilton. 40% of the bed blocking in the hospital was being caused by 9% of the patients. The reason being that their patients had dementia and the nursing homes were not prepared to deal with that, or they were obese. What blows out the backs and knees, the number one thing for personal support workers is they don't have the right tools to lift people, the right machinery. So what happens is when you throw money at a political problem like we always do, and this has been going on for years and years and years, you don't actually solve the real problem. The other thing, someone had brought up earlier about how great our doctors and nurses are, and I totally agree, but they're to blame too. Because for the last 20 years, they've been sticking their finger into every dike to try and keep the whole thing from collapsing. Had they let it collapse 20 years ago like they should have, like any normal person would have, the politicians couldn't have got away with all this crap about saying...
Not quite part of the Hippocratic Oath to let the whole thing fall apart.
I understand, but they've made it worse because the politicians, because they lie all the time, have managed to pretend the system is okay. In fact,
let's get...
the 10-point plan, number one is stop lying to us. So I could accomplish one thing, that would be the best thing
was
of all.
number one.
Yeah.
Kate, does social prescribing have anything to tell us about how to resolve the differences between these two?
It really does. I mean, the debate can't center only on hospitals. Hospitals play a really important role. And reducing hallway medicine can't just happen at the back door, getting people who are in the hospital out. We have to keep people from entering hospital. We have to do some work at the front door. And that's where community health really comes in. So social prescribing is a way to move people from primary care to community, but we also need to be moving people from hospital to primary care. Primary care is where people have long-term relationships with the health system throughout their lives. And that's really where the coordination of their care has to happen to do all that prevention work. Some of that's really clinical, some of that is less clinical and more social, and a lot of it is cooperative and happens at the community level.
Does social prescribing have a view on whether or not we can improve the healthcare system with a private parallel system versus a single payer status quo the way we have it now?
We are invested in the public system. It's very important for us to make sure that, in particular, people who are facing the biggest barriers to health and well-being get the care they need. That doesn't happen under private care, and it often doesn't happen under certain models in our public system that are disincentivized to care for the most socially complex people, people who are marginalized, people who are racialized, people who come from LGBTQ communities, French speakers, and so on. They are often not well served under the public system, but community health centers have a mandate to backstop the health system and to be there for those populations in particular, and so their needs are best met in a public system.
Dr. Webster, I want to ask you whether or not your vision for increased access to better technology, like the PET scanners that you care so much about, whether that is more effectively enhanced in a private parallel system, or can we do it in the current single-payer system?
I think most systems in the world have always had parallel systems. We're one of the few countries that doesn't. But I would like to just step back for a moment because you've said lots of wonderful things about the Ontario healthcare system, and you're wrong. I can say that.
Who are you talking to?
Well, everybody. I mean, we've been talking about quality and about you're right that Canadian physicians, Ontario physicians, are some of the best trained in the world. The problem is you're led to believe you live in a patient's first evidence-based system. Nothing could be further from the truth. We are officially last in the world amongst OECD countries when it comes to access to 2019 levels of care. Ontario doctors are forced to practice medicine as if we were living in the 1990s. Why is that? I will be controversial to my colleagues. The system is not about the patients. It is about, in particular with the Ford approach is going to be, is about ensuring that politically powerful medical subspecialty groups' incomes are not threatened by PET. As an example.
Name names, yeah, what do you mean?
Okay, well, what I mean by that is I believe the stats now are that 2, for example, in 7 radiologists in the province earn more than $1 million a year. And if PET was introduced properly, and what I mean by properly is something I've been saying to the government since I was president of the Ontario Association of Nuclear Medicine back in 2004, we should only be paying for diagnostic imaging tests if they can be shown to advance the patient's management properly, right? But they don't get paid to read PET scans. So the problem is that
Sorry, say this.
they don't. The radiologists are not qualified.
Radiologists don't get paid to read PET scans.
Only nuclear medicine physicians.
So their income would take a hit.
They could easily lose 60%. In other words, if in the States, interesting, you talk about the United States model, they've actually are ahead of the system in some ways. If you came into with a chest x-ray with a 3-centimeter nodule, say, in your chest, They wouldn't even let you order a CT because they know the next way of best managing that is with a PET scan. For example, if it has about a 40% chance of being a cancer, this nodule, right? But if you do the PET scan and it takes up an enormous amount of sugar, we now go to in excess of 95% probability of it being a cancer. And often on the PET scan, we'll find examples where it's actually already spread to a little lymph node sitting behind their neck. And I have an 83-year-old patient who, in Ontario, the only place in the world, in order to qualify for a PET scan, you have to stick the needle in the lung nodule first. She collapsed her lung. She was in a terrible situation. They put a chest tube in. She was in the ICU and so on. But the bad news was the biopsy wasn't even cancer positive because the CT can't tell where to put the needle. But it got even worse for her because it turns out the PET scan showed something that nothing else can show. She had a lymph node sitting behind here.
The big question is how do we get more of these things or better access to these things?
Because you've got politically powerful medical groups who don't want access to
Okay, that's Natalie, I'm going to bring you in there. Do you believe it is the case that we have, there's an old expression that the lions look at each other differently when the well runs dry, right? Do we have a situation in Ontario where everybody's out for themselves in terms of healthcare stakeholders and they're not seeing the big picture here?
There certainly is, that's a tough question, but there certainly is, you can even see it here. Everyone who's sitting here wants more of the money and more of the resources that are available either in the system or by making people dig into their pockets and handing them more money
Well, you say
for
making,
themselves.
he would say allowing people.
Right. Well, they would have to at that point, right? But for them, they want it, he wants it for his, surgical centers, you want it for the community health centers, you want it for the PET scans. Someone has to actually manage how we provide healthcare, the best healthcare for the most people possible, given our population demographics and so on. And yeah, I do think that there are lots of vested interests in the system that push very hard for that money to go to themselves. I think that happens without question.
Dave?
Well, I take strong exception to that because you see, the point is we have way too many PET scanners,
But that's
or sorry,
what
way
you
too
just
many
said
CT,
also.
way too many CT scanners and MRs. They've handled this, by the way, in Quebec, if you'd like me to detail on that. But the point is that we don't need those CT scanners and MRs. We keep replacing them, and we don't need them. As I said, if we did, the patient who had 30 CT scans, they only needed 3 PET CT scans. That's the problem for the radiologists.
We should be going to this next
So the
area.
point is, we don't need the CTs. And interesting, if PET is done with the CT scanner, we could do it with a lot less. And by the way, I've introduced this to everybody, including Doug Ford. The way that PET is done in the U.S. is now more than 50% actually comes off a mobile PET CT. Now the point is, in Sudbury, I've been trying to get this for the past 7 years. I ran the very first mobile PET in Canada. The only cost to the hospital to have that thing physically there next week would be a 220-volt line to plug it into. Hoskins was on the radio trying to, shut me down over things like that, the former health minister. But the point is that I've made it very clear, we actually could have a much cheaper healthcare system with a lot less diagnostic imaging tests. You have to understand that when you're screening kids for radiation exposure to all these CTs, they wouldn't be done. Those 30 CTs wouldn't even be done.
Kate's trying to get in here. Go ahead.
Yeah, I just wanted to speak to that idea that everybody's out for themselves under this system and that there are some powerful interests. I want to give a powerful example of an innovation that's undergoing right now that includes social prescribing but is a little bit broader. Right now, we're working with many partners across the health system to link those people who have just a solo physician or a non-team physician with the team-based care that they need. So we know people need a broad range of different kinds of supports, either in the community or within the health system, or to specialists. But individually practicing physicians just can't handle that load alone, particularly for their clients who are really medically complex or socially complex. So we're actually linking those solo practitioners with teams that aren't just community health centers, but mental health agencies, social support agencies, and so on, without having to change governance, just by working together, and without having to change billing codes. Doctors want to participate because it helps them. It frees up their time to work on other cases that are more relevant to what they're doing, and they get the support they need to do that other work.
Stephen, let me ask you about, we had Christine Elliott, the health minister, on the program last week, talking about the significant restructuring that she has unveiled. Do you think that's a step in the right direction?
It's a step in the right direction, but it didn't go nearly far enough. I'm extremely disappointed. Once again, it's rearranging the deck chairs on the Titanic. And it's funny, they even use the same language that the Liberals did for 15 years. The transformation agenda was the Liberals. And they're talking about, we're going to transform. Well, you're not going to transform anything. What you're doing is you're bringing a bunch of deck chairs into one super agency which is fine, but you got to fire people. You got to reallocate the resources. Simply taking the 14 LHINs full of liberal hacks and those type of people that got appointed, and not frontline care people, and putting them into one super agency, and allowing them to continue doing their thing, but in a different building, quote unquote, virtual building, whatever. That's ludicrous.
I'm not sure that's going to happen.
Well,
I
that
think
seems to be what I'm reading. But
I think the minister didn't want to say it, but the reality is there are some bureaucrats who are going to lose their jobs.
well,
and
there
she's
have
talking-
to be a lot. And see, let me just scare the hell out of millennials and iGens who probably think they don't have to worry about this stuff. And here's what I mean when I'm talking about an accounting problem, and that's why we really need to be working on that problem, not just rearranging the deck chairs. So my generation, the boomers, will receive, and this was a study that I talk about in the book, will receive $4,000 more health care in our life than we paid for in taxes. Because again, you're always kind of paying for the generation ahead of you. The millennials will pay $18,000 more in taxes than health care received, and the iGens will pay $27,000 more in taxes than health care received. Like, that is a huge problem. There's too many of us. We're too expensive. We're not dying quickly enough. There's not enough of them. They often don't have full-time jobs, or they're in huge debt graduating university. There's a variety of issues. Until we get real and have what I call that adult conversation, which is why when the book came out, I was hoping that this year, in this ramp up to the federal election, we'd finally have that adult conversation and make healthcare the #1 issue of this election, because politicians will always say, well, I'm for the Canada Health Act, I'm against two-tier healthcare, and that's great. But here's the problem. If you are for the Canada Health Act and the status quo and the Canada Health Act and all that sort of stuff, and you're going to push for that, you will end up with the very thing you're afraid of, which is a US-style two-tier healthcare system. Because by 2030, 100% of the budget is going to be spent on healthcare. And Dalton McGuinty had that great line, there'll come a day when the only ministry we can afford is the Ministry of Health, and we still won't be able to afford the Ministry of Health.
Okay,
so unless you're willing to privatize every school, every road's a toll road, and have no money for infrastructure, et cetera, because it's all going for healthcare by 2030, that's what you're doing by telling people the system's sustainable. It simply isn't.
I am down to my last minute here. Natalie?
Well, it's
wanna
the
come back
same
on
old
that?
create a crisis and then, privatize. That's the language here. And the truth is that healthcare really is about people. And what we hear from are thousands of seniors, literally thousands of seniors, who are being pushed out of hospital with nowhere to go, without proper long-term care. People who are lying on stretchers in hallways, yes, for weeks sometimes, waiting for care. Communities where they see their local hospital under threat of closure. We actually do need more resources. We are far below the average of the rest of the country. There is room for that to improve access. And any innovations that we actually bring into the system, we should guard very carefully that they're in the public interest, that they serve patients and not private interests.
I have a very simple solution that I proposed long ago. The American insurance system actually works properly in some ways. We should only be allowed to let doctors order tests that there's a reason to order it. Right now, for example, in radiology reports, it's not uncommon for 70% of those reports to recommend yet another radiological investigation. Quebec's handled this. But the point is that there's way, way, way too many diagnostic tests done because people get paid to read them. And as I said, 70% of the time they recommend another test.
You know what, Dr.
You
Dave?
want to do that.
We need another show. We've barely scratched the surface here, and we've gone at it here for more than a half an hour. Thanks, everybody, for coming in from near and far to join us tonight here on TVO. We're grateful you shared your views with us tonight.
Yes.
Thank you.
Thanks so much.
The Agenda with Steve Bacon is brought to you by the Chartered Professional Accountants of Ontario, helping businesses stay on the right side of change with strategic thinking, insightful decisions, and business leadership. Are you on the right side of change? Ask an Ontario CPA.